I'm Dr. Neil Kalman, the Chair of Family Medicine and Community Health at Sinai. And it's my pleasure this morning to introduce Dr. Inga Peter, who's a professor and vice chair in the Department of Genetics and Genomic Sciences at the Icahn School of Medicine at Mount Sinai. Dr. Peter received her PhD in genetic epidemiology from Tel Aviv University in Israel and completed postdoctoral training at Tufts. Her research goal is to better understand the role of host genetics and the microbiome in the development of complex diseases with the focus on inflammatory bowel disease. Dr. Peter is also a principal investigator on a series of genetic and systems pharmacology studies of cardiovascular, metabolic, and renal comorbidities associated with antiviral therapy in persons living with HIV. In addition, she's Associate Director of the PhD program in clinical research and Director of the Institutional Early Career Development Program. We're honored to welcome her here today to talk about bioethical considerations in the use of personal genetic information, something that's very germane as we continue to expand the work that we're doing, the research work and the outreach work that we're doing in genetics as family docs. And we've been very involved in this for a number of years. So it's with great pleasure and anticipation that I turn it over to you, Dr. Peter, and thank you for joining us this morning.
Thank you very much, Dr. Kalman, for a kind introduction and for inviting me to speak to your group. So just let me know if you can see my screen.
Looks good. Yes, we see it.
Okay, perfect. And I'd like to be an informal discussion. So if you have any questions, please feel free to stop me anytime. I don't really see I don't see you, so just unmute yourself and feel free to ask a question. So the topic today will be personalized medicine, bioethical challenges, and the use of personalized information. So I will start with just the whole idea of personalized medicine. So this is a kind of buzzword in the last couple of years, and different people mean different things. And the major focus when we think about personalized medicine is genetics. So if we can incorporate the wealth of knowledge that we've accumulated over the last decade or maybe 2 decades since the development of the Human Genome Project, the idea would be to really make it much more informative and accurate to make the diagnosis, to predict the disease development, and maybe improve the treatment. So, so when we talk about medicine, what we actually mean that we're moving away from empirical medicine when we had the same treatment for everybody using evidence-based and or even stratified medicine where we applied it to large groups of people. The personalized medicine would be to treat each patient individually, use the overall evidence-based medicine, but also patient-derived information. And when we talk about patient-derived information, it's very important to remember the role of the environment. So yes, we are absolutely unique in our genetic composition, but what really triggers the effect of our genes, or what can significantly modify the risk of genetics, would be environmental exposures, nutrition, lifestyle, early life, antibiotic use, microbiome. I can go on and on and on, and eventually it will all be translated into some metabolic responses that should be taken into account in order for personalized medicine to really work. So we've been witness to increased use of genetics in the last couple of decades. So paternity testing, right? So it's so easy now to just take a buccal swab from a child and potential parents and get a very, very accurate result. There is forensics, understanding disease pathophysiology that can lead to the development of novel drug targets. Once we find mutations associated with diseases, we can target the pathway. Development of genetic tests to predict disease, to issue some kind of disease modification measures, personalized treatments through selection of drugs that would target particular mutation, just like in cancer, or relabeling drugs when they actually act on a particular pathway or a gene with if a mutation is existing in this gene and the response could be unpredictable. Also use it for the prognosis. We are also very interested in our ancestry, and there are a long list of ethical, legal, and social issues associated in epigenetics. So I will start with the definition of personal genomic information. It is an information about individual that is based on the results of personal genetic testing, specifically for variants identified as being associated with either traits or diseases, or based on unbiased whole genome or whole exome sequencing without any particular question in mind. And these results need to be returned to an individual or their healthcare provider. That's by definition of personalized genomic information. So the 5 types of personalized genomic information, it could be rare mutations associated with monogenic diseases. That's what we've been doing for a long, long time now for prenatal diagnosis and for diagnosis of rare developmental disorders. There is a carrier status for someone with the early onset cancers and other diseases in the family to identify individuals at risk. There are also DNA variants associated with high risk of diseases such as Alzheimer's disease, Parkinson's disease, or age-related macular degeneration, where genetic tests are very highly predictive of eventual disease development. There are also common genetic variants that only slightly increase the risk, and I'll give us a few examples in a moment, such as hypertension and type 2 diabetes. Also, variants associated with response to treatment or pharmacogenomic variants, usually in cytochrome 450 genes. There is a panel of genes available. Some people will be grouped into either poor metabolizers or extensive metabolizers, and that would help to either select a different drug or gouge the dose so that there will be side effects. And as I said, ancestry is also important, not only for us to know, learn about our ancestors, but also it's gonna be more and more used in clinical practice. And then also out of curiosity, we can use genetics to determine some physical traits, other traits, height, boldness, and etc. And the big issue in the field of clinical genetics is genetic variants of unknown significance. These are commonly found through this unbiased screenings, such as whole genome, whole exome sequencing. And then there is a big dilemma, what should we do about them? Whether we should notify the patients about them, whether we should just wait and see whether some new information will come up, and then use this information for clinical decision making. So there are numerous benefits of getting or using personal genetic information. So it may help enable risk-reducing behaviors or lifestyle changes, enable risk-reducing actions such as referrals for doctors for additional tests, such as colonoscopy, mammogram, or lipid blood tests. It may provide relief and reduce uncertainty for some families with high risk of certain diseases running in the family. It will satisfy some curiosity for some people, and it will provide some information regarding loved ones or their children to make sure that the genetic risks were not passed on, usually by guilty feeling parents. It will also inform about reproductive decision making if there is some carrier status involved prior to pregnancy or during pregnancy. But there are also significant risks associated with misinformation. It can be easily misunderstood or misinterpreted. It can lead to some genetic determinism or even fatalism. It may generate some false reassurance that someone is not going to develop a certain disease, which may not necessarily be true, especially for diseases that are not have a very strong genetic component. It may lead to stress, depression, anxiety, increased uncertainty instead of decreased uncertainty, especially if the test is positive. It could have some implications for privacy, insurance, employment, implications for family relationships, and also people may just regret the decision of generating this information, and that's not uncommon, and it happens with people who really, really want to have it and still regret it later on. So this is just a few examples that I like to share with you, all kind of appetite for generating this information among the US adults across the board. So here you can see that about half of the people are either interested or someone interested to get their whole exome sequenced. It's even more than a half. Whereas about 40% are either not interested or definitely not interested. This is very consistent with what also would do for their children. So maybe the same pretty much number, maybe less so, but definitely interested in getting the same information for their children. And it also varies by different groups. Women, parents with children with 2 or more health conditions are more likely to be interested in generating this information, whereas people with conservative views are less interested in generating this information. But when we talk about the need to generate this information and apply it to clinical practice, it's very important to understand what this information can actually provide and how to interpret it. So it's also very important to understand that a genetic information is not even or evenly applies to different diseases. And that's where the spectrum of disease etiology is very important. So it ranges from diseases that are genetically determined, where mutation in a gene or in a number of genes is either sufficient or necessary to cause the disease, such as hemophilia, cystic fibrosis, and all the way to mostly largely environmentally caused diseases such as smoking-related lung cancer or skin cancer. However, the majority of complex late onset diseases are multifactorial, where both gene and environment are involved. And it makes it very difficult to really understand what's contributed by the genes and what's contributed by the environment. And I'm talking about most of cancers, cardiovascular disease, neurodegenerative diseases, etc. So when we are talking about genetic diseases in genetics, we usually mean 2 types of genetic models, either monogenic disease, as I said, the gene is sufficient and necessary to lead to the disease. However, we are also dealing with complex diseases where genetics only predisposes slightly to disease, or increases susceptibility, but there is no causality. So for polygenic disease, if someone is a carrier, there is 100% chance to have the disease. Sorry, I clicked something. For breast cancer, carriers of BRCA1, BRCA2 have significantly higher risk, like 80% risk of developing breast cancer or ovarian cancer compared to non-carriers. For colorectal cancer, also individuals who carry risk mutations, they have significantly higher risk than the general population who are non-carriers. And the best example is the BRCA1 breast and ovarian cancer story. We are well aware of Angelina Jolie's struggle. She lost her mother to ovarian cancer, and then she tested positive for BRCA1 mutations. She was told that she had an 87% risk of developing breast cancer, given her mutation status, and then given preventive measures such as mastectomy, surgery, she decided to undertake. Her risk for breast cancer went down to 5%, from 87 to 5, which is even less than that of an average woman in the general population, which is about 12%. So another example is Parkinson's disease. So Sergey Brin is a co-founder of Google. His mother was diagnosed with, I'm sorry, it's the wrong order, was diagnosed with Parkinson's disease at the age. He tested positive for the risk mutation in the LRRK2 gene. So this is just some information that a risk for developing Parkinson's disease in the general population is about 1%, but those who carry the mutation, depending on whether they carry 1 copy or 2 copies, the risk goes up to 30 to 75%. And there is actually no prevention for Parkinson's disease, except for some anecdotal evidence suggesting that some, regular exercise and drinking green tea may reduce the risk. And he also donates significant amounts of money to the Michael J. Fox Foundation. That is actually, its mission is to find a cure or prevention for Parkinson's disease. So what's really common between these two stories? So both have a family history, they both tested positive, and both something about it. Right? The differences are that the risk reduction of ovarian cancer is very, very high with a certain measures, preventive measures, whereas there is no prevention strategies currently available for Parkinson's disease. And another example is overall, if we communicate genetic information to a broader population, a general population, the question is, how willing are they going to be to really follow the advice and change their lifestyle? Because it's not going to be for a week or two, it's going to be for a long time. And this is an interesting study that was conducted to return the results of Alzheimer's disease genetic risk genotype ApoE4 to the general population. So the lifetime risk of Alzheimer's disease is about 10%, but it's 30% in people with 1 copy of ApoE4 variant and 80% in people with 2 copies. And up until now, even though these tests are available, it's considered to be unethical to really provide the results because there is nothing that can be done. It's also true for age-related macular degeneration because there are no real prevention approaches. But this trial was different. It was called the Risk Evaluation and Education for Alzheimer's Disease Study, or REVEAL study. And this is where participants were randomly assigned to either getting genetic testing results back or not. And then they were informed that there is no real evidence, but there are some measures that they can undertake to potentially prevent or delay the development of debilitating disease. And this just results from the impact of the return of personalized genomic information in this trial with regard to the changes in vitamins and dietary supplement use. What you can use here that after 6 months of revealing the results, individuals who were tested positive and were notified about being tested positive, they increased their self-reported intake of vitamins and supplements by 30%. Whereas those who did not carry the variant still increased it by 8%, and the difference was statistically significant. I checked yesterday to see whether there are any other follow-up studies to this study, go beyond 6 months and see whether these patients or carriers rather stick to this healthier diet and take more vitamins beyond 6 months. Unfortunately, I didn't find the results, but there are other examples, especially with smoking related lung cancer, when individuals are advised to quit smoking as a result of carrying some of the disease predisposing variants. And they were only able to do it for a couple of months, and then they returned back to their smoking behavior. And then the justification was that, you know, I carry it, I'll die anyway, at least I will enjoy it. So, and then the second type of genetic risk is the genetic risk for complex diseases. If you look at type 2 diabetes, the lifetime of developing type 2 diabetes is 33%, very high. See how much the genetic predisposition is. Sorry, I don't know why it keeps going. So here, for example, people gamma is one of the top genetic risks associated with type 2 diabetes, and you see the risk goes up only slightly. It's even less so for CAPN10, and TCF7L2 is one of the major common risk factors, and it still goes up only from 33% to 61.2% here, and it's probably even less than the risk of having obesity or other lifestyle behaviors that increases the risk of type 2 diabetes more than any of these variants, or they're all combined. So it's very important to really realize what what genetics can or cannot explain. And then it's very important that in 2008, there was a Genetic Information Non-Discrimination Act that was released that forbids discrimination on the basis of genetic information when it comes to any aspect of employment, hiring, firing, pay, promotion, layoffs, training, etc. Under this act, it's also illegal to harass a person because of their genetic information, and there is also a confidentiality of genetic information. It's unlawful to just disclose this information to employees or to even medical health insurance, because they can potentially discriminate if someone is a carrier and may deny coverage. It's very important, I think, for our patient population to know that this act exists and that we take it very seriously, genetic information, because there is significant fear regarding disclosing this information. And this information, genetic information, is incredibly powerful. What we can learn from the DNA sequence of an individual, in addition to their sex and to their ancestry and predisposition to other diseases, it's more powerful than any other information that we can release. Also, there are social, legal, and ethical implications of genetic testing. So each genetic test that is developed raises serious issues for medicine, public health, social policy regarding circumstances under which the test should be used, how the test should be implemented, and what uses are made of these results. Should people or patients or consumers be able to control access to results of their tests? If the tests are released to their employees and insurers, what kind of protections should be put in place to ensure that they're not treated unfairly? What about other important issues such as education? What if patients are able to get these results done, how these results will be interpreted, whether they will be interpreted correctly? And that brings me to the next topic of DTC genetic testing options, which is direct to consumer genetic testing. It's been for a long time considered like a recreational genetics because many companies misrepresented exactly the power of the data that they were distributing or its interpretation, but it's getting better now, and it's possible to get ancestry information just like we heard before earlier. There is family relatedness that can be obtained from getting genetic testing through direct to consumer and finding missing family members. It can also help identify carrier status, disease risk for common diseases and monogenic diseases, and also response to drugs, which can help in the future to prevent adverse effects, but also to prevent a situation when a patient is not responding to a drug because of being extensive metabolizer and having an insufficient dose. So Ancestry.com, I assume that many may have used in the past, very inexpensive. It was suggested last year as the best gift for Father's Day, so it's very easily approachable. The same is by 23andMe, where you collect your buccal swab and you just send the tube to one of these companies or other companies, and they generate our information. So for example, Ancestry is how the information is being generated. So on the left-hand side, you see each chromosome, so 23 chromosomes, and then you see the color-coded are parts of different ancestry. So you can see that ancestry doesn't come from one particular chromosome. It's comes from one parent. So we see two bands for each chromosome, one coming from the mother, one coming from the father. So you can clearly see that some chromosomes there are, you can see that they're coming from one ancestry when the other chromosome is coming from a different ancestry. And this particular individual was defined to be determined to have 99.5% European ancestry, and within European ancestry, it was broken down to some sub-ancestries, and then there is some other Middle Eastern, North African ancestry, and it can also be shown here. Another individual, when you see the map of the world, and it's color-coded, and it shows all the regions where the ancestry is coming from. So in this particular case, it's European, East Asian, some sub-Saharan, and some also unassigned, meaning there was no good reference in their database to assign almost 9% of the genome. But we all should be aware of what genetics cannot do. And there are a lot of misinformation, and I was really in shock when going over those where it says that you can identify inborn talents for your babies and identify those who have athletic talents or should go into sports versus other activities. I was really disheartened when I read some testimonials saying that I'm so grateful to this site because now I'm not going to waste time for my daughter on a day and instead I'll sign her up for chess. It's not there. It's not available. This information is incorrect. And it's very important that our patients and we as consumers are well aware of what genetics can or cannot do. And if we use this precious information, that we use it wisely. So a few questions for discussion that I just list here, but please feel free to ask any questions. So should people be allowed to choose or refuse genetic tests? Or should it be mandatory as newborn screening is in some states? Is direct-to-consumer genetic information helpful or harmful? How should I prepare as a consumer for personalized medicine? And I will just add a few more things in terms of the education. So genetic information, it's not something that can be easily interpreted. It can be easily misinterpreted, but it's very important that both the patients and the providers know what to do with this information. And the more direct-to-consumer genetic information becomes available and easily approachable, and patients come to their primary care physicians or any other specialists with their results and asking to act upon them, it's very important that our medical students are taught what to do about these results, how to interpret them, how to act upon them. So, I will just stop here. I had some slides, but I just will stop here and see if you have any questions or there are any topics you would like to discuss.
Thank you, Dr. Peter. That was really excellent and raises lots of questions. Of course, the best lectures are the ones that raise more questions than they answer because it's truly on the cutting edge. I would start by just asking, how much do we know about the epigenetic part? Like, how much do we know? I was moved by the chart that showed the difference between those monogenic caused diseases and those that were more environmental. But for those that are in the middle, which I think more and more of them are going to show up in the middle, how much do we know about the environmental factors that actually alter the gene expression?
So the answer is we don't know that much. And the reason is because when we conduct these studies, collecting environmental information is much more difficult than collecting genetic information. It may sound like too over-optimistic, but it's so easy and inexpensive to generate genetic information nowadays. It's so accurate that it's not indisputable. What's really difficult is the phenotyping, the accurate phenotyping, and also collecting detailed environmental information, and then applying it and looking not just for the effect of the environment, but for a modification. Risk modification. In other words, there are numerous examples now demonstrating that if you carry a particular genetic variant, let's say for obesity, FTO gene, you will have a higher BMI and you are more predisposed to cardiovascular and other diseases. However, if you are a carrier and you perform a lot of physical activity, your BMI will be lower than those without risk variant who are not performing physical activity. So at some point, the risk modification is so strong that it overcomes the effect of genetics. And we know very little about it because first, the numbers, right? Statistically, it's very difficult to identify not just the effect of environment, but how it interacts with the genetics, how it acts in the presence of mutation or in the absence of mutation. It's the same with smoking. If someone is not a smoker, the risk is minimal. But if someone is a smoker, the risk goes up. So epigenetics is an excellent tool. I haven't heard of really using epigenetic data for any clinical decision-making or genetic testing. It's all at the level of research. Issues of epigenetics as opposed to genomic DNA is that epigenetic signatures differ from tissue to tissue. They change with age. And while genomic information, it doesn't change over life. You can get it when you're an infant, and it will be the same throughout life. So these, additional pieces of information, while very valuable, they're very, very complex and difficult to really incorporate into disease risk prediction.
Thank you.
Dr. Peter. I have a question from the audience. The risk of misuse of genetic information is a known risk in communities of color. How do we begin the dialogue with our patients around this concern, where the risk of their personal benefit is weighed against the concerns raised from historical misuse?
Absolutely. This is a great question. I think that one way to address it, and we've been trying to do it through focus groups, to go to community, to have community leaders and just present the data, demonstrate our willingness to work with the community, to demonstrate the benefit of using genetic information to benefit the community, and address their fears. They're not baseless, right? So we are embarrassed with what happened in the past, and we just need to address that. However, there are examples, clear examples of, you probably know better than me, the Bioethical, right? Bioethical is the only drug on the market right now that is prescribed to individuals of African American ancestry, right? So it's not based on any biomarker or any number. It's just African American ancestry. So, and that works really well in this population and not other population. Or the risk, for example, of breast cancer in individuals of Ashkenazi Jewish ancestry. If we ignore that fact and we treat everyone equally, we will miss a lot of opportunities to prevent disease and treat disease properly. So I think it's just the education. I believe, I'm a big believer in education. I think that's the only way to demonstrate the benefit, to educate the community in a benefit of genetics, and prove them that we are ready to protect their information and only use it for their benefit.
Thank you. I have a comment, kind of. I'm just going to read it out. It is interesting to think of epigenetics in the context of health disparities and the effects of systematic racism as an environmental factor. If you have any comments.
Absolutely. Yeah, absolutely. Absolutely. We had a paper published by one of our faculty that has shown that the gene expression in the nasal cavity of patients of African ancestry for a certain gene associated with COVID entrance to the body, the higher gene expression could potentially explain the higher rate of COVID in this community. And the paper was criticized heavily. Our faculty was threatened, her life was threatened. And a journal, JAMA, who published the paper, they completely, there was a request to withdraw the paper. And I think that the major reason that happened was the choice of words, right? Because people say, instead of wasting your time on this type of research, you better work on something else. Why would government pay for such racist research? right? But it's very controversial, because if that's indeed the case, and the gene expression is not something that, is a stigma, right? So if that's indeed the case, and these levels are higher, we can try and prevent it, and we can target this community to prevent it better and decrease the risk of transmission. So while I completely agree that it can be easily misinterpreted, immediately, I just want to add one more thing. When people were commenting about this paper, they were bringing up issues of intelligence and IQ, which had absolutely nothing to do with it. And I can feel the pain. I could feel the, pain of these people of constantly being, feeling this way, and of this systemic racism. But I think we should make sure that we turn genetics into a tool to improve everyone's well-being and health, as opposed to using it to further discriminate between people. And I think it's very important. It's probably it's not easy to do.
I just would comment that I think one of the things that happened with that was that people felt that it created an excuse that basically said you don't have to look at some of the environmental factors and the factor of poverty and the factor of people living in close quarters and the infectious nature of the disease. And more recently, there was a paper published that showed that the oximeters that we use they underrepresent hypoxia in the Black population, and that the darker your skin is, the more it underrepresents your oxygen level, and therefore overrepresents your oxygen level, and therefore the color of the light and these devices represented some causality, right? So I think that the issue is, how do we balance the genetic information but not use it as an excuse to say, oh, well, there's nothing we can do about it, right? And I think it's very complicated, and it's a place where we can't just grab our armament. We just need to we need to really try to understand all of the issues that are at play.
Dr. Peter?
Absolutely, and gain the trust.
Yeah, this is Dr. Schiller. I have a question about education. Do we know if people have done any research on how to educate people around these issues? Because it seems to me there's a way of thinking about this that's somewhat foreign, to just, how do you deal with statistics? How do you deal with uncertainty? And it strikes us both for those of us who are training for professions, as well as, should this be something that's taught in schools, to help the next generation in our communities to try to understand how to think critically about these issues and how to apply them to their own communities. So are there any educational research studies that you're aware of, and how we can do a better job?
So there are a lot of studies done, starting from medical school, where education in interpreting and returning genetic information is addressed, and but I'm unaware of anything happening in schools to address that. And I agree with you that should happen very, very early on, and people should be equipped to deal with this, information, and have, be able to make informed decisions going forward. There are a number of clinical trials that were at least initiated, where genetic information was provided to patients but not clinicians, and then clinicians but not patients, both and neither, and looking at their behavior. And it's very interesting that how people, sometimes even clinicians misinterpret the information as something that is, you're destined to have it, while you're getting information about a 30% increase in the risk of type 2 diabetes, which you know, it's good to lose weight, absolutely. But, you know, overreacting to it. So I think there's so many different aspects to it, right? So in terms of the racial aspects, in terms of the participation in research, right? Participatory research, it's heavily skewed towards whites, and then it's not generalizable to other populations who actually would benefit even more from this research. So I think a good start would be to try and you know, convince people to participate in research studies so that we can learn how they should be, you know, how their health should be addressed, not just through genetics, but like you said, through health disparities and access to care. But we really need to have these people in our studies. And I don't know if you know, you are having these discussions with your patients.
Could you talk a bit about the All of Us program? We're going to be participating in it. I think we are already. And I know that there are a lot of ethical issues that come up around that program and the ability of folks to, you know, to hear about genetic information in the future that evolves and stuff. I think it would be really helpful for people to hear your perspective on that.
So All of Us is probably the largest ever initiative generated by the NIH to try to recruit a large number of individuals, because in genetics we have a big issue of statistical power and the numbers. We need tens or hundreds of thousands of people to just, you know, conclude on the effect of certain genetic risks in the population. So All of Us was kind of approach to address the issues of sample size by recruiting people that would represent the US population. So it wouldn't be people who are usually participate in research studies, and use their clinical electronic medical records and link them to a number of biospecimens collected by this research group. So it is a very large initiative. Initially, the goal was to recruit 100,000 individuals and follow them up and see whether they develop incident cases of certain diseases, if they develop comorbidities, and then go back and see whether there are any kind of biomarkers that occurred before the diagnosis. They're considered collecting stool samples. I gave several talks for different about programs in the past, especially with regard to the microbiome, which is not part of usual, you know, research studies. But I think the overall goal is it's essential. It's essential to get a better understanding of the, you know, overall population and all of the information associated with their health prospectively, in order to make any changes in, you know, clinical care.
So in family medicine, we're particularly interested in social determinants of health, the people's social circumstances. So, but we don't collect that regularly. Is that included? Are those kinds of things included in the electronic health record? And would we be contributing more to this study if we were collecting that information on our patients who are going to be participating?
Absolutely, because this is the most critical information, is the social determinants. Because as I said, genetics is very easy to generate from just a buccal swab or a blood test. What really will make a difference to understand what kind of access they have to healthcare, to understand their willingness to their trust in the system, to assess their level of mental health and how much it contributes to complying with therapies, or the financial burden of getting some therapies available. I think it's more important than anything else. And as I said, don't worry about genetics. It's so easy to get this information. The more environmental exposures and surrounding information you can collect in a more organized way, the more helpful and powerful this initiative will be.
Dr. Peter, I have another question from our audience. How do you see the cost of personalized genetics being made more widely available, where it is not just available for those with the means to pay for it? Have insurance companies, including Medicaid, been supportive of this laboratory cost?
Absolutely, that's a great question, very relevant question, but there are some answers to it. So what we are trying to do with our research, we're trying to demonstrate that by applying personalized medicine, whether it's Medicare or commercial insurers will save money. And therefore, they should support it and they should cover genetic tests because it will reduce the number of adverse events, it will reduce the comorbidities, and eventually they will end up paying less. And that's why I think the evidence-based medicine and cost effectiveness analysis are critical to demonstrate that eventually they will benefit from doing it. I'll give you an example, pharmacogenomics, right? So pharmaceutical companies are, encouraged, but not mandated to provide genetic information for the drugs that they're asking for approval. And this genetic information may actually improve the effectiveness of the drug. However, the pharmaceutical companies are very concerned about a drug becoming, orphan drug with a genetic test required because less people will be, prescribing, less, fewer physicians will be prescribing, less people will be taking the drug if it requires genetic tests, and then to cover the cost, and then it needs to be interpreted correctly. People would prefer just to go to blockbuster drugs and not use those. And that's why they're never presenting this information. And that's the pharmacogenomic actually research is coming from academia because there is no incentive for industry to do it. But I think it's critical going forward for us to really know who will benefit the most for different drugs. And if we can show this to insurance companies, then can ask this from pharmaceutical companies to provide data on what would be the best way and who should be prescribed. And then I believe when the costs will be covered. And there are a number of genetic tests that are already covered by insurance companies. For example, for warfarin prescription, in some places it's covered for early undiagnosed conditions. Whole exome sequencing is fully covered by insurance. So I think it's just a matter of time when we are able to demonstrate the benefit of genetic tests, so it's covered.
All right, we have another question. There is a company called Genomic that does pharmacogenetics for mental health drugs and pain medications. How useful is that information today? If it is useful, why isn't it used before we prescribe those drugs to anyone starting them?
So could you please repeat the first part? What information?
It does pharmacogenetics for mental health drugs and pain medications.
Pharmacogenetics, yes. So again, they're not interested in orphan drugs that require genetic testing. And pharmacogenetics is all about stratifying people by their carrier status and assessing their response to drugs. And then you can see if someone is a poor metabolizer, then, and you have a genetic test, then you need to decrease the dose. Otherwise, it will be a high rate of adverse events. Or if someone is an excessive metabolizer, you need to increase the dose because the drug immediately leaves the system without having any impact. So, and that creates, you know, a different subgroups or additional burdens. So pharmaceutical companies are not interested in pharmacogenomics, unfortunately. So, and that's the same for mental, you know, conditions, for depression. And that's why programs like All of Us or BioMe Biobank and the programs that you are participating are so important, because that would give an unbiased answer to who really benefits from these drugs. When you look back and you see, okay, everybody was prescribed, but then those with particular genotypes responded better than others, and that means that's what, you know, should happen going forward, like with CLIP emerge, right, to flag carriers for ALP1 genotype in order to change the, you know, management, clinical management.
So this question might already have been answered in your last response, but is there evidence of improved outcomes for patients when genetic testing for drug metabolism is done for SSRIs, and is there actual clinical utility?
Not yet, not to the best of my knowledge. It's been looked at for a long time. It's very complicated. I spoke with a few people here at Mount Sinai that are prescribing these drugs, and they say there is not sufficient information. It's not something that is currently being used. I think going forward, I know that they mentioned to me that patients come to them and say, I want this information to be included in your decision making. So it may even come from a pressure from the patients eventually. But currently nothing, you know, across the board is done to use this information.
Thank you. All right, we're nearly at the end of our time. Dr. Kalman, do you have another question?
No, just to say this is really evolving. We need to bring you back once a year so that we can get updated on where things are at. You know, this is stuff that we learned nothing about in medical school that many years ago, and people who are learning about it this year, even in 2 years, their information is going to be obsolete, and there'll be so much more to learn. So we'll continue to, you know, be updated on various things. And thank you for this great information. And we hope that you'll accept an invitation to be invited back and update us periodically.
I'll be happy to be back, and thank you very much for having me.
Thank you. Have a good day, everyone.
Thank you.